Thanks, Neil. Okay, so I'm going to start off. I'm going to talk about a disorder that doesn't exist, traumatic mind injury. And I'll start by saying my goal here is not to propagate yet another disorder. I think we have enough disorders without really understanding them at all. We don't need more. But I'll try and explain, and hopefully by the end of this, you'll have some idea. Maybe I'll even have a better idea what it is I'm trying to say. What do I do with this? But so just quick disclosure in terms of consulting work and other potential conflicts. I'm going to start by thanking people, and I've been trying to kind of keep up a list of people that I thank for work over the years. I've been working in this area for 30 years now, and the list has gotten long, and I'm becoming more forgetful and worried I'm not going to put people on it who should be on it. So this is what I'm doing at this point. So the work I'm going to be presenting today is really the work of dozens of people, many of you sitting here, and students, recent students, past students, and lots of collaborators both around the country and the world. So I thank all of you. So what are the objectives? So I want to start by providing a bit of a perspective on how common these mental health syndromes are that are associated with traumatic injury. I'll talk, of course, about post-traumatic stress disorder, but also about post-concussive symptoms, PCS. And one of the themes is going to be to try to have us consider the possibility that these somewhat disparate sets of symptoms and responses to trauma may have shared etiology. And Neil had pointed out that the bio sketch I gave him had lots of abbreviations. This talk has lots of abbreviations. Those of you who've been working with the military, the DoD, will realize they just love abbreviations. When I started working in the area, I'd be on phone calls and people would be throwing around these abbreviations. And I had no idea what they were talking about. And I'd be Googling them. And in some cases, there was one call, we had a call with someone called the ODUSA. And I must have had 6 calls before I finally said, who the hell is the ODUSA? It's the Office of the Deputy Undersecretary of the Army. I had no clue. So I think for you, you probably are very familiar with most of these, but I'll try and explain what I'm talking about. So DSM-5 did make some changes to PTSD. It was actually one of the more eventful sets of changes to any of the diagnostic criteria that came along. And I won't go through all the criteria, but of course what's unique about PTSD is that even though we value and think about and talk a lot and teach about sort of a biopsychosocial approach to understanding diagnoses, most of our diagnoses don't require that anything happen to you in order to get them, right? Major depression, sure. Most people get major depression, have something going on in their lives that's stressful or bad, or they've had a loss. That is not part of the diagnostic criteria. PTSD, you need to have had something happen to you, and even that's a little gray. I'll talk about it in a minute. But you have to have had exposure to a traumatic event in order to have the disorder. And that's fairly unique among our psychiatric disorders, that recognition. Something has to have happened. What has to have happened? It has to be something that's really, really bad. Bad in what way? Theoretically, life-threatening. But as you can see, DSM-5 kind of hedges its bets because we don't really understand how close you need to have been to the trauma, how much it needs to have directly impacted you, indirectly impacted you to have an impact. So, the trauma can involve actual or threatened death, injury. They specify in DSM-5 sexual violation. You can directly experience it. It can happen to you. You could witness it in person, So you're standing on a street and you're looking across the street, you see somebody else get shot. DSM-5 says you can get PTSD from that. Then you can be one more level removed. You could have heard that it was your friend who was on the street who got shot, but you weren't there. You learned about it. You heard about it. Somebody phoned you and told you about it. In that case, it says, well, then it has something really, really violent or accidental. If somebody slowly died and you learned about it, you couldn't have PTSD from that. You can start to see how we're getting into these fairly silly gray areas. And what it comes down to is that there are individual differences in how people respond to these kinds of events. Some people, they're Navy SEALs, you could drop a building next to them and they won't blink. And then you've got other people who will hear about the horrible things that happened today in Belgium in the airport, and they can be pretty traumatized by it. So one of the things we'll talk about this morning are some of the individual risk factors for PTSD. So this sort of gives you an idea of, criterion A is the traumatic stressor. It's very much depends on your perspective. This could be a criterion A trauma for a chicken. And so and DSM-5 has tried to do this, to kind of say, these are the kinds of things that can give you PTSD and other things can't. You got to be this close and it's got to be accidental is a very, very difficult thing to do. Now, fortunately, when we're working clinically and we're treating patients, we're not trying to figure out if they deserve a disability payment, or we're not working in the courts. We're there with somebody who says, this thing happened to me, and as a result, I have all of these kinds of symptoms. We just go ahead and treat them. You don't have to worry about, was the stressor sufficient to give them PTSD? They got something, and if it's not PTSD, it's darn close. We're going to treat it that way. So DSM-5 kind of added a set of symptoms to what we had thought about PTSD for a long time. There was always this triad of after something traumatic happens to you, you have the re-experiencing, which is the sine qua non of PTSD. You have the avoidance, and you have the hyperarousal. DSM-5 added in a fourth dimension, as if it wasn't complicated enough to begin with, that they refer to as negative cognitions and mood. This is kind of a nod to the fact that so many people with PTSD also have major depression. There's been some debate in the field whether it's really major depression, as if we actually understood what that was as a distinct entity. But the consensus, and it wasn't unanimous, of the DSM-5 committee was that they should roll in these negative cognitions and moods. They're so common and make them part of the disorder. So that's what they've done. In reality, as you all know, it's far more complicated than that. The avoidance can be thought of as being of two types. The actual act of avoidance, people don't go near things, don't go to places that remind them of the event. But then there's the emotional avoidance, trying hard not to think of it and feel what happened. And that's what we call emotional memory. And there's other symptoms that are very much part of PTSD, and in some cases what results in them presenting for treatment. Problems with anger, problems with guilt, and it's a very, very complicated picture. How common is PTSD? So in the US, the epidemiologic studies in the general population suggest around 3 or 4% of people have PTSD. It's higher over a lifetime. And like many of the anxiety and depressive disorders, there's more women affected than men. Part of the reason women are affected more than men has to do with the kinds of traumas that they're exposed to. But part of it seems to relate to innate susceptibility to these kinds of problems that we don't understand the etiology. So anytime somebody throws up a slide for you and says, prevalence of something is X percent, you want to ask more questions. One of the questions you want to ask, was it uniform? Is this kind of anybody in the US is likely to have it? And we know there's very special populations where there are much, much higher rates of PTSD. I'll give you 2 examples. Studies that have looked at American Indians living on reservations find rates of PTSD 2 to 3 times higher than the general population. You can imagine why that's the case. A lot of it has to do with poverty and trauma and psychosocial circumstances. And in fact, among American Indians living road to Orange County, where you know there's a very large Cambodian refugee population. This was a study done now about 10 years ago, but at the time, they surveyed in the general Orange County Irvine area folks who were Cambodian refugees, now about 20 years on average since they'd left Cambodia. The 12-month prevalence in that general population sample in Orange County was 62%, meaning more than half the people in the community had PTSD. And it was a result of exposure to Khmer Rouge atrocities. Almost everyone had been tortured. Virtually everybody had a family member that was killed. So there are these subpopulations, even in our country, where exposure to trauma is dramatically different than the norm, and rates of PTSD are tremendously high. And one of those subcultures that we're all very familiar with is the military. In the past 10 years or so, with the new conflicts in Afghanistan and Iraq, there's, of course, been a whole new generation of soldiers who've developed mental problems related to war and combat and deployment. And these are data from the U.S. Army. You may know that the U.S. Army, actually all the armed forces, routinely do surveillance for PTSD and depression and alcohol. So whenever somebody comes back from deployment, they're given a screener. You've probably seen these screeners. And these are data that have been published that come from those screeners. And just, we don't need to go into all the details, but you can see that 14, 15% of returning soldiers from an index deployment have major depression. About 12, 13% have post-traumatic stress disorder. And so those are the folks that are being seen and treated in military mental health settings and eventually find their way, many of them find their way into the VA setting. If you take a look at the burden of mental illness on the U.S. Armed Forces, it's really kind of staggering. So this is a recent report from Army Medical Surveillance. And what it does is it lays out all the different categories of disease. I don't know if you can read them, but number one in terms of its impact, and the impact here is measured in terms of medical encounters, is not surprisingly injuries and poisoning. It's mostly injuries. Number two in terms of impact are mental disorders. And then, even things like broken bones and other kinds of internal injuries are less frequent. So mental disorders have a huge impact on healthcare use in the armed forces. And if you break it down this way and you take a look at here's medical encounters, here's hospital bed days, and here's lost work time, looking at mental disorders, you can see the huge chunk of disability that was attributable to them. It's actually the biggest piece in terms of hospital bed days, one of the biggest next to injuries in terms of lost work time. So there's a tremendous negative impact, not just on the individuals, but on the armed forces overall, and the costs, both in terms of actual dollars, disability, and quality of life is staggering. Outside of the military, what kinds of trauma types cause PTSD? So in the U.S., the most common is different types of criminal victimization. Rape and intimate partner violence, both of which inordinately affect women, and is one of the big reasons there's more PTSD in women than men in the general population. Motor vehicle collisions are high up there, and then the impact of things like childhood abuse and natural disasters. Unfortunately, more and more as we're hearing, terrorism. So let's focus for a couple minutes on traumatic physical injuries. If somebody is in a motor vehicle collision and they break a leg, or somebody is held up at gunpoint and actually shot in the shoulder. So there's a fair bit known about the likelihood of developing PTSD after having a physical traumatic injury. What are some of the risk factors? Women more than men. Not surprisingly, the extent of the physical injury, more broken bones, higher injury severity, greater likelihood of developing PTSD. Also, maybe not surprisingly, the extent of chronic pain after the injury is a predictor of PTSD, both development and chronicity. This is a risk factor that comes up in all PTSD studies. Folks with lower education or lower IQ, it's kind of sometimes hard to know which of those is central, are at greater risk for developing PTSD than those with more education or higher IQ. If your injury involved an ICU stay, you're more likely to get PTSD, and that's probably a combination of the fact that you had a more severe injury that got you into the ICU, but it also has to do with the things that happen in an ICU that can themselves be traumatic, particularly when people are sort of in an altered mental state, maybe delirious. That seems to increase risk. And then a very strong risk factor is, irrespective of all the other risk factors, if the injury involved your brain, if you had a traumatic brain injury, your likelihood of developing PTSD is higher. Let's take a look at that. Spend a couple minutes just talking about mild traumatic brain injury. And I know that many of you sitting here are experts in the area. We see this in the context of military injuries, and I think that's what has actually drawn a lot of attention to mild TBI over the past decade. We hear a lot about it in terms of sports injuries. This is a study taking a look at visits to emergency rooms in the United States for TBI. And as you can see, around 2008, there was this big uptick. This slide goes out to 2010, where people were making many more visits to the emergency rooms in the US for traumatic brain injury. Now, does this mean more people were sustaining TBIs during that time period? I mean, hopefully not. What it likely means is that there was an increased awareness of TBI. So whereas people used to get their head whacked and their bell rung, whatever sort of euphemisms we would use, particularly in sports, they didn't do anything about them. Now people are much more likely to seek care. Doesn't mean we necessarily know what to do with them when they seek care, but they're showing up more. TBI can be graded. This is a brief sort of summary of the different gradations of TBI. So mild TBI is a concussion. Those are synonymous. And it's interesting just to look at the mild TBI criteria. The criteria differ a little bit depending whose criteria you're looking at, but they're not that different. So you had a force injury, concussion injury to the brain, resulted in some loss of consciousness, but it could also be an alteration in consciousness. So many people don't lose consciousness at all. Things feel different. So you can start to see there how difficult it is to actually pin down. Even did somebody actually have a concussive brain injury? Because something happens and you get frightened, you get hurt, and you feel weird. You get a little spaced out. Did that actually involve a brain injury or not? Hard to know. But the loss of consciousness, by definition, if it's there, is less than 30 minutes, which by itself is a very big range, right? You can be out for seconds, or you could be unconscious, unresponsive for 30 minutes. That's a huge range to throw all that into mild TBI and pretend that they're all kind of the same. And then the same with post-traumatic amnesia. You can have a mild TBI and have post-traumatic amnesia for 23 hours. And, that's a pretty significant brain injury. Moderate is even further loss of consciousness, post-traumatic amnesia that's even longer, and then severe. So there's a lot of dissatisfaction in the field with these definitions, in part because the mild group, which virtually nobody studied 10 years ago, is now being studied a lot, and there's this realization that there's just way too much heterogeneity in that group to be able to make sense of it. So PTSD, as you know, overlaps and has a lot of comorbidity with other disorders. I've already talked about major depression. You know that there's tons of substance abuse among people with PTSD, chronic pain, and PTSD kind of mutually reinforce each other. And then, of course, TBI. And one of the difficulties in understanding the association, the relationship between PTSD, post-traumatic stress, and post-concussive symptoms is that the definitions, the syndromes themselves that we try to identify overlap. And they overlap in part because, for the most part, until recently, psychiatrists and psychologists work with PTSD, and neuropsychologists and neurologists worked with post-concussive symptoms, and the criteria kind of evolved independently. And as you can see, there are some distinguishing characteristics of PTSD, re-experiencing symptoms, probably in particular. There's some distinguishing symptoms of post-concussive symptoms: headache, sensitivity to light and sound, memory deficit, dizziness. But at the same time, we know that many people with PTSD have a lot of somatic symptoms, so they're not that distinguishing. But then most of the core symptoms are core symptoms of both disorders. So after somebody sustained an injury that involves trauma, involves possible head injury, they may have either or both of these, and it can be very difficult to separate them, and it makes conducting research in this area very difficult. Now you start thinking, okay, if somebody can have experienced an emotional trauma that maybe they didn't sustain any physical trauma at all. There are many situations like that. The person who saw somebody shot across the street and sustains an emotional trauma clearly didn't sustain a concussive injury to their brain. And then there are other people who did. Why can there be this kind of comorbidity? Well, it could be that the emotional and the concussive trauma result in changes or injury in brain systems that involve a common pathophysiology. There could be structural changes, there could be cellular and molecular changes. We'll talk about some hypotheses there. You can think about it from a neurocognitive perspective, that particularly when there is a concussion, but probably also when there's a strong emotional trauma, those traumas knock offline some of the systems that normally keep us psychologically healthy. And in the case of TBI in particular, when somebody sustains a concussion, you take offline a lot of the frontocortical systems that are involved in problem solving and emotion regulation. And there may be damage to fiber tracts that involve connectivity between some of the limbic regions and those frontal cortical and prefrontal cortical symptoms. And the theory is that doing that, even for a brief period of time, can set the individual up and render him susceptible to these mental health problems. So I'll tell you about some work we've been doing with colleagues on a project called Army Stars. This is a study that was funded by NIMH. The funding actually came from the U.S. Army to NIMH, who then ran the grant. We've been looking in particular here about traumatic brain injury and the risk for mental illness. So Army Stars is actually a big multi-component study. For discussion this morning, I'm going to focus on one piece of that study. This is called the pre-post deployment study, and it involved a little over 8,000 soldiers. And we have about 5,500 who we've been able to follow and have data on at all the time points prospectively. I'll tell you about the study. The Army gave us permission to interview 3 sets of brigade combat teams before they were going to be deployed to Afghanistan. So this was not easy to arrange. You can imagine the Army is pretty secretive about who they're going to send where and when and who's going to be involved. So we, meaning the research team, we got notice a couple of weeks ahead of time that, okay, we're going to deploy this brigade combat team, which is a group of about 3,000 individuals. They're going to be going to Afghanistan. Come on, get over here now, do your work, do your pre-deployment assessment, because they're going to be deploying soon. So University of Michigan, which was responsible for collecting the data, had literally a small army of researchers and research assistants fly down to wherever the base was, and we would do our surveys and draw blood and do additional assessments on essentially everybody in the brigade combat team. So we did that with 3 brigade combat teams, within a month of their deployment to Afghanistan. It turned out they were all deployed to Afghanistan. And then we were given access to them again as soon as they were redeployed to the US. After, in this case, it was all about a 6-month deployment. That's our T1, our time one. We reassessed as many individuals as we could find, which was about 80%, 2 to 3 months later. That's our T2. And then had a third assessment 6 to 8 months later, and that's our T3. So a longitudinal study. So pre-deployment, before they were deployed to Afghanistan, these are some of the characteristics of the individual. The U.S. Army is 15% female, but women are less likely to be deployed to places like Afghanistan, or at least that was the case a number of years ago. So the sample here is even more predominantly male, 95% male. For about half of them, this was going to be their first deployment. But about 20% had a prior deployment, and you can see many had had multiple prior deployments. So even then, before this index deployment, around 10 or 11% of them had PTSD, either related to prior combat trauma or in most cases related to non-military trauma. And then when they came back, literally the day they came back, we gave them a very, very brief survey that tried to get an index of what kind of exposures they'd had during their deployment, hopefully while it was still fresher in their memories. And we had a number of questions and put them together into a deployment stress exposure scale that ranges from 0 to 50. We also asked questions about their exposure, this is based on their self-report, to concussions during that index deployment. About 80% said they didn't have anything that they thought was a concussion. About 1 in 5 by self-report sustained a concussion, and then there was a small group that wound up being more severely injured and hospitalized with TBI. So about 1 in 5. This is pretty consistent with other studies in the literature, had a new concussion during the deployment. So this is adding up to 100%, the different kinds of disorders that people came back with. So this is their 3-month post-deployment assessment among individuals who had sustained a concussion. So there's a little over 700 of them, which is about 13% of the sample, had these different disorders. And they didn't have them before. So you can see there's a bunch of PTSD, but that's not the only disorder people have. There's major depression, there's generalized anxiety disorder, there's new onset suicidality, and you can see how they also all overlap. So one of the things we learned from this is that it's not just PTSD that is a consequence of deployment. I think this is well known, but this sort of exemplifies it. There's this whole set of anxiety-related and depressive disorders that increase following deployment related to TBI. So if you had a new TBI, you were one of those individuals, one in 5 who had a new concussion while you were deployed, your risk for having PTSD doubled compared to people who didn't have a TBI. This is after adjusting for which brigade combat team you were in, your age, race, gender, number of prior deployments, all of which do influence risk for PTSD. You still doubled your risk if you had a concussion. But it wasn't just double the risk for PTSD, it was double the risk for major depression, generalized anxiety disorder, and a little more than double the risk for any of them. So we know a fair bit about risk for PTSD in general, and risk for PTSD in relation to having a TBI. We don't know a whole lot about why some people recover from a traumatic brain injury, from a concussion, and why some don't. So after concussions, if you look at, say, sports injuries as an exemplar, people who've had a mild traumatic brain injury in a sports injury, about 85 or 90% are doing really well a week later, and within a month, about 90 to 95% are asymptomatic. Then you got 5 or 10% of people after a concussion who don't get better. They have persistent we don't know a whole lot about why some people are more or less likely to recover after sustaining a concussion. Some of the risk factors that we think we know about have to do with things like age. So younger individuals are at greater risk for having persistent symptoms. Again, it shows up women more than men. Of course, a lot of it has to do with the severity of the injury, the type of injury. There's been interest in genetic factors, whether or not ApoE4 and other genetic factors might increase risk. I think it's still controversial. There's really been nothing that's been definitive. Probably the biggest factor that seems to increase risk for non-recovery from a concussion is the association with mental problems. So if somebody has a concussion and they develop depression, they are much less likely to recover even from their neurocognitive symptoms. If they have PTSD, they're much less likely to recover. But overall, the data are still not very good. We took a look at this in the Army STAR sample. This wasn't a hypothesis that we planned to look at a priori. And so we cobbled together, we didn't have a post-concussive symptom measure in the study. But it turned out we'd asked about a lot of somatic symptoms and actually were able to piece together this 8-item post-concussive symptom scale that actually seems to work pretty well. So in this case, we're looking at the same subset of individuals we have follow-up data on from the pre-post deployment study. Here we're looking at about 6,000 where we had data pre-deployment and 2 to 3 months later. I mentioned that about 20% reported having a concussion during the index deployment. They came back with more post-concussive symptoms and didn't have a concussion, so that's a good thing. It suggests that the scale has at least some face validity. What did we find out were risk factors for non-recovery from your concussion, for having persistent post-concussive symptoms after a TBI? We found in our sample women were at greater risk than men, almost 2 to 1. Prior concussion, if this wasn't your first, the more concussions you had, the less likely to recover, very consistent with the literature. And then some things we probably didn't expect to find. So the extent to which you were having mental health problems, kind of refer to this euphemistically as distress, but the extent of mental health problems prior to deployment increased your risk for having persistent post-concussive symptoms after a TBI. Then, also surprisingly, the same severity of deployment stress exposure that increases risk for PTSD also increased risk for not recovering from your concussive symptoms. You have evidence that if your mental health wasn't good before you went to deployment, when you sustain a TBI, you're less likely to recover from it. And if you were under a lot of emotional stress, the kinds of things we think of as resulting in mental disorders, and they do, it increased your likelihood of not recovering from your TBI. These risk factors essentially overlap entirely with those for PTSD. We'll talk a little bit about biomarkers. There's a lot of interest in now understanding more about the neurobiology of PTSD. Many of you folks are doing some of the best work in the world in terms of looking at biomarkers. Let's talk about a little bit of the work that we've done in relationship to Army STARS. In this case, looking at inflammation and not at post-traumatic stress symptoms, but here at post-concussive symptoms. So there's theoretical evidence pointing to a role for inflammatory processes in post-concussive symptoms. So we did a nested matched case control study within Army STARS. We had plasma on all of the soldiers who'd been deployed before they were deployed. And then we had plasma again when they came back. Here we're actually looking at their pre-deployment plasma. We had 3 different groups. So we had soldiers who sustained a TBI during their deployment and had a lot of post-concussive symptoms. Those are our cases. We had soldiers with TBI but had very few post-concussive symptoms. That's one of our control groups. And then we had another control group with no TBI. They were matched on everything we could think of to match on. In this case, we were measuring interleukin-6, an inflammatory cytokine using a high sensitivity assay. So this is, again, looking at their plasma pre-deployment in relationship to post-concussive symptoms. So what we see overall is that, at least compared to one of the comparison groups, the cases, the people who went on to develop persistent post-concussive symptoms had higher IL-6 levels on average than the control. These are data from the Marine Resilience Study, Baker, and Carolyn Evergelt, Vicky, Risborough, and lots of other folks here have been leading this study, where they showed that plasma C-reactive protein, a very non-specific inflammatory marker, seems to be a biomarker for risk for PTSD. So again, we've got some coming together of shared risk along in the inflammatory domain, at least, to the extent that we can see this from peripheral markers, maybe linking post-traumatic stress symptoms and persistent post-concussive symptoms. So as I mentioned, there's some evidence, it's still pretty preliminary, of increased peripheral and CNS inflammation in post-traumatic stress disorder. One of the questions is whether or not this is actually a cause or an effect. We know that people with PTSD have lifestyle changes that could lead to them having more systemic inflammation. For example, things like weight gain, metabolic syndrome are associated with increased CRP levels, are associated with PTSD. It's very difficult. One wouldn't want to say that one is etiologic for the other. Interestingly, IL-6 physiologically drives CRP levels, so there's a natural link there. And at least makes you want to wonder and do more work looking at a common etiology for post-traumatic stress and post-concussive symptoms, maybe even a role for anti-inflammatory treatment, although I think it's still a little too early to go down that road. We have a very good sense of research done over a couple decades now by lots of groups around the world about PTSD risk. We understand a lot about risk for PTSD. We know that having childhood maltreatment, even if it didn't itself result in PTSD, increases risk for PTSD when someone's traumatized later. Having a personal or family history of another anxiety or even depressive disorder increases risk. Being a woman increases risk. Having low IQ increases risk. Characteristics of exactly what happened during the event are associated. There's now quite a bit of information about specific genes that I'll talk briefly about that increase risk for PTSD. We know that if the trauma involved physical injury, it increases risk, particularly if that physical injury involved traumatic brain injury or a concussion. And one of the things that is important to remember in all of this is that we arbitrarily draw a line between PTSD and non-PTSD. So we say, if you got symptoms, more symptoms, and you're to the right of that line on that normal-ish distribution, you have PTSD. If you're to the left, you don't. Of course, that's completely arbitrary. And it's very important to remember that, because studies that say we had a group of people with PTSD and a group of people without, many of those without share pathophysiology with those who are to the right. It's just always important to keep in mind that we use these diagnoses as a shortcut. Let me talk about genes. You have to be old enough. So you've heard lots over the years, over the past 10 years probably, about a variant, polymorphism in the serotonin transporter promoter region, where, recall that all of us have 2 copies of every gene. And for this particular variant, there are 2 versions, a long version and a short version, and they influence the serotonin transporter protein that's made. And this is a summary of research looking at individuals who carry 1 or more copies of the short allele for this variant. And many risk factors for anxiety, depressive disorders, PTSD maybe in particular, seem to be carried along with having more copies of this S allele. These are things like having differences in fear conditioning, differences in auditory startle, differences in HPA reactivity, attentional biases to threat. So not a disorder. It's not saying that people who are S carriers are more likely to have major depression. In fact, that's probably not true. More likely to have PTSD. That may or may not be true. But it does seem that they are more likely to have some of these traits, physiological, cognitive, that would increase likelihood of them developing PTSD when they're exposed to trauma. But there are some data suggesting that carriers of the S allele of the serotonin transporter promoter polymorphism actually are more likely to develop PTSD. So this is sort of an experiment of chance, where in February of 2008, there were shootings at Northern Illinois University, and the shooter killed 5 people and wounded 21. Relatively small campus. Just so happened that Dr. Mercer, a psychologist, had been doing some studies prior to the shooting, and she had data on PTSD symptoms in a group of female undergraduates before the shooting. That's time 1. She was just studying for something else. You can see on average their PTSD symptom scores are very low. The shooting happened, small campus, people either heard the shots, they were around, they saw people running, they knew somebody hurt, so a lot of trauma exposure. On average, this is now after the shooting, 17 days on average later, everybody's symptoms, PTSD symptoms, are higher. But carriers of the short allele have higher, significantly higher PTSD symptoms than those who weren't carriers. So in this one study, it does suggest that that particular gene may increase risk for PTSD given exposure. So we've kind of gone from the era of candidate genes to looking now at genome-wide association studies. There's been a number of these done. We've done one in Army Stars that I'll show you. Carolyn Nievergelt and Lean and their group have conducted a GWAS, and in fact now the world's coming together, led by Carolyn and others, doing into a PTSD collaboration where everybody's pooling their data, and eventually the field will be at a point where we'll have a lot of power to look at risk genes for PTSD. So this is from our single study from Army Stars, and this is looking at the African American subsample. And it's important to do that. There are reasons that it's difficult and probably can't combine different ancestral groups when doing the GWAS analysis. So this is these are findings from our African American subsample. It's a relatively small sample, and you get lucky if you find something. Here what we found is one genome-wide significant hit on chromosome 5. And I don't know if you can see, but you can also see there's this trail of other SNPs that are probably associated with it. Kind of zoom in now on that particular locus. And what this is then a set of markers linked on the long arm of chromosome 5 in a gene that's actually pretty well studied. It's called the anchor and repeat domain 55. The function isn't known, but what's interesting is that this gene has been associated with multiple autoimmune and inflammatory disorders. There are associations from GWAS studies with rheumatoid arthritis, with Crohn's, with MS, with type 2 diabetes. It's an interesting gene. Just to do a quick genetics refresher, there's this concept known as pleiotropy. And pleiotropy is the idea that a single gene can influence more than one trait. We looked in our data. At possible pleiotropy between our GWAS data for Army Stars for PTSD How do we do that? We went to publicly available databases. So other people have published GWASs in rheumatoid arthritis, psoriasis, multiple sclerosis. And we looked at their data, and we looked at our PTSD data, and then used the statistical technique to be able to examine pleiotropy, basically asking the question, do we have a bunch of genes that we're finding are associated with PTSD that others have also found are associated with these autoimmune disorders? So do we see evidence of pleiotropy? We did. We found significant evidence of pleiotropy for some of the markers influencing PTSD and rheumatoid arthritis and psoriasis. So this gets us back to the idea of how and why and when would we want to think about something along the lines of traumatic injury, traumatic mind injury. So we know that some types of injury-related TBI are more frightening and actually life-threatening than others. So not all TBIs are alike. Sports injuries, most people who get knocked out in a football game don't think they're going to die, unless it's 6'9", 400-pound lineman running at them. I would think I was going to die. But most people playing football don't feel that way. It's very different if you sustain a concussion because a bomb went off and somebody next to you is dead, and you wake up and you're delirious and you had another physical injury. So it could be that not all TBIs are alike. When we're studying TBIs in the context of deployment in war, we're getting a very different contextual slice of trauma exposure than we are sports concussion. We do know that physical injury is a major risk factor for PTSD, especially if it involves TBI. We want to at least ask the question whether or not having post-traumatic stress symptoms after an emotional trauma and post-concussive symptoms after physical trauma to the brain may be the same disease. And if it is, why would that be important to know? Well, it could be that there's a subset of individuals with post-traumatic stress symptoms and post-concussive symptoms who maybe have some sort of inflammatory process. Can we look at different symptom profiles to tease those apart? Is there a common mechanism or etiology? And then the bottom line would be, would there be some predictable response to treatment that we could pull out of that that would tell us, aha, this individual needs treatment A, this individual needs treatment B. We'll just kind of finish off with a bit about treatment. There's very little known about treating traumatic brain injury in particular and concussions. And in terms of persistent sequelae after a TBI, there are no medications that are approved by the FDA for treatment of post-TBI depression or any other post-traumatic neuropsychiatric problem. Doesn't mean people don't have those problems. They do. And the physicians and other individuals who treat those people are therefore using medicines off-label. There's a lot of off-label use for TBI because there's nothing on-label. I want to share with you results of a trial that colleagues conducted as part of our Entrust Consortium. This was our DoD-funded 10-site consortium, mainly intended to do clinical trials. And Ariel Lang's the co-director. We're just actually winding down now 8 years of research projects with this consortium. This was a strange study. Tom McAllister, Ross Safont, who are well-known TBI experts, and we designed a study where we were going to take individuals who had what you could think of as being what I'm kind of jokingly referring to as traumatic mind injury. Who were these people? People who came into the study who had persistent emotional and cognitive symptoms associated either with PTSD or TBI. So we were looking for individuals who had concussion and or PTSD and had persistent neurocognitive symptoms, so typically attentional problems, memory problems, irritability. And we wanted to randomize them to a couple of the treatments that are used off-label, one of them being methylphenidate, Ritalin, another being galantamine, and then placebo. So we designed a what we thought was a very cool randomized controlled trial for those individuals. And we started the trial, and pretty early on into it, the DOD stopped the trial. It wasn't the DSMB, and it wasn't our scientific advisory board. It was government steering committee for reasons that are still unclear to all of us. And as you can tell, we're not the least bit bitter about it. They said, you know what? We just don't like the trial. Stop it. So we stopped it. We were very disappointed, but we said, you know, what the hell? We randomized 32 people. Let's take a look. So these are the results of our trial, and they're published recently in Neuropsychopharmacology. We randomized, turned out, about 11 people to Galantamine. So Galantamine, of course, is a drug that's used for Alzheimer's. 9 to Methylphenidate, used for attention deficit hyperactivity disorder. 12 randomized to placebo. Here's the result. So we had measures of post-traumatic stress symptoms and post-concussive symptoms, both of which were considered important, although our primary, we were looking to see if we could change post-concussive symptoms. And it's a little difficult to see, but what we've got is over the 12 weeks of study among the people randomized to methylphenidate, galantamine, or placebo, you can see that one group is doing a lot better and was statistically significantly better at virtually all time points, and dramatically better. And anybody want to guess which drug it is? Methylphenidate. So in a study that turned out to be, should have been remarkably underpowered, we saw these sort of startling results, even with post-concussive symptoms, early on, and quite sustained. So so you'd think, given that as far as we know, these are the most remarkable results. These are the most remarkable results I've ever seen for either PTSD symptoms or post-concussive symptoms. Small study, who knows, could be a fluke, but at minimum, you would think that people would be lining up to fund our next study. They're not. I'm still not sure why. Maybe some of you can help me figure it out later. I think part of it has to do with the drug itself. I think there's concern about methylphenidate, and concern that that might not be the kind of drug you want to give to people with PTSD or post-concussive symptoms. Reality is that people with PTSD and post-concussive symptoms are being given methylphenidate. They're giving a lot in, for some reason, Siri's talking. They are being given methylphenidate a lot without a good evidence base. So we're still hopeful we're going to be able to do a larger randomized controlled trial. So just to finish off, what I tried to cover was a brief review of PTSD. PTSD, again, is unique because it involves this exposure to emotionally traumatic events. Post-concussive symptoms are a consequence of exposure to concussive forces to the brain. So it's really important to kind of think about even changing our terminology. We really shouldn't be saying that somebody who has persistent symptoms after a concussion has TBI. They don't. TBI is the injury itself. The equivalent in PTSD is the exposure to the emotional trauma. Then most people recover from their emotional trauma. Most people recover from their hit in the head, but some don't. Those individuals we're trying to understand, why don't they recover? What's common about them? How can we treat them? Post-traumatic stress and post-concussive symptoms frequently co-occur, and the incidence of either increases risk for the other. From the risk factors we've looked at so far, they're shared for post-traumatic stress and post-concussive symptoms. And this then kind of raises the question, that I'm really just going to end with the question, of whether this response to trauma could represent a distinct disease. Does it have a predictable trajectory? Will it have a predictable response to treatment? Really kind of going out on a limb. We might wonder whether an early intervention target, trying to prevent this from becoming chronic, might be to do something that requires working on inflammatory processes, some sort of anti-inflammatory treatment. Later on, when this is chronic, maybe inflammation isn't involved so much more, but now you've got more of a scarring kind of problem. And from what we've seen with methylphenidate, maybe treatments that can enhance executive function, not necessarily pharmacologically, although that's an option, might be a very important intervention target, both for PTS and for post-concussive symptoms. We'll stop there, and thank you very much.
Much for that really elegant description of a broad phenomena that's probably been part of the human condition from day one, when saber-toothed tigers were chasing after us. It's something that our society has also done a lot to cause over the generations, and that news is more of that last night. Let me open this up to questions from the audience. I'll pass around the microphone here.
Thanks for this, a very elucidating talk. A couple of questions. First, what's the role of the sleep-wake cycle? I mean, I understand that someone who's had trauma, if you keep them up and you don't allow them to sleep in the immediate aftermath, that is actually beneficial because they won't lie down their memories. And alternatively, for TBI, initial work on the progesterone and anesthetic was very helpful. And I couldn't help thinking that with the methylphenidate, which works primarily on dopamine, and dopamine has been found to be the mediating agent for the antidepressant effects of sleep deprivation. So I wonder how the whole role of the sleep cycle fits.
So there's a lot of interest in looking at the relationship between sleep and recovery from concussions and recovery from PTSD. It's it's very clear that people with PTSD have chronic sleep problems, and a lot of people think that even meaning the primary focus of treatment on improving sleep, sort of a chronic state, may be beneficial. So, initially, one of the newer treatments, relatively newer treatments pharmacologically for PTSD is prazosin. One of the things prazosin seems to do is improve sleep in people with PTSD, but you also see effects on daytime symptoms. It raises the question of whether or not just improving sleep and in and of itself is beneficial. Exactly what happens acutely, around the time of the trauma, and the whole question of do you want to prevent the laying down of traumatic memories, or do you want to enhance the laying down of a memory? Is having kind of an incomplete memory, is that what results in PTSD? So do you want to consolidate it, or do you want to get rid of it? It's still very unclear. But I think that there's no question that sleep and sleep's effects on memory and memory consolidation are probably very important. I just think we don't yet know how we should implement it.
Now, the other question was sort of emotional versus the role of emotion versus physical trauma. This is more of a personal question. You don't have to answer. But I remember you telling me that after your emotional trauma, the VA, it took you 2 years to go back. That after your bike accident and a significant physical trauma, I'm curious how long it took you to get back on the bike.
Yeah. So this is actually revealing that I'm not very bright. I got back on the bike while I still had a PIC line. So it also may say something about the traumatic effects of VA versus bike crashes. But I've also gone back to the VA.
Oh, I had 2 quick questions. First, you didn't really say very much about substance abuse and its relationship with PTSD. And the other one's a totally different question about epigenetic effects. And I'm kind of wondering about generational epigenetic effects of cultures that have been exposed to stress.
Yeah, so there's lots about PTSD I didn't talk about. There's a lot now. So clearly there's a lot of substance abuse that begins after onset of PTSD. We have started to look at this in Army Stars, and NIAAA has funded us to look at that, and also to look at gene by environment interactions for trauma and PTSD in relation to substance abuse. And say is that individuals who develop PTSD in our pre-post deployment study do start drinking more, they start using more other drugs, there's more cannabis, there's more opioid use. There's definitely a relationship there, and it's exactly what's causing what and why. So we haven't done any intergenerational work on PTSD, but there is a literature suggesting that trauma exposure among, it's been looked at Holocaust survivors and their families, now even the second generation beyond that, there is an increased risk for PTSD. It may be related to epigenetic effects on glucocorticoid receptors, but still very hypothetical.
So I really liked your emphasis on mind injury and how that might be similar between PTSD and post-concussive syndrome after TBI. You talked a lot about risk factors. I'm wondering about protective factors and not just kind of the opposite of the risk factors, but for example, what about psychological traits like resilience? Is there any evidence that people who are sort of more resilient before deployment in terms of their the way that they approach the world are somehow resilient to these traumas in terms of their mind reaction?
Yeah, it's a difficult question. It's not a difficult question to answer. It's a hard thing to study because it does become circular at so different point, because we've actually gone in and tried to define resilient people. So rather than saying, let's look at the people who developed PTSD, let's look at the people who didn't develop any of them. They're resilient. And then you have to even go a step further. You have to say, well, if they're really resilient, we should only look at the subset that had a lot of trauma, where we know that, on average, that group is 4 times more likely to develop problems. Let's look at the people who had lots of trauma and still didn't have anything. What were they like before? And, not surprisingly, what they were like before is they didn't have much in the way of mental disorders. On a resilience scale, they are much more resilient. The resilience scale, of course, is problematic because it basically asks people how resilient you think you are, kind of thing. We can only ask that in so many ways, but they at least think they're more resilient, and it turns out to be true. And then what we've been doing now is we've been trying to do candidate gene GWAS analyses on numbers of things to actually see if we can look at genes that influence resilience prospectively, starting to find some interesting things.
So two questions, I guess. One, in regard to measuring the IL-6, how did you account for it? When we in the serious CSF studies, we see a lot of variability across times. How did you account for that? The other is, can you discuss? Most of the inflammation is major peripheral. I've come to believe that the peripheral inflammation is at issue, but how do you account for the relationship with the brain?
So our IL-6 was all measured at different times. Most of the samples were taken between 8 a.m. and noon, but we don't have any more fine-grained tracking of exactly what they were taking. And that's true of a lot of the biological samples we have in stars. So we have the advantage of, in some cases, we have 100,000 samples, and we hope that the signal will outstrip the noise. And in some cases, that may be true. In others, it may be very important. Exactly, when certain things happen, it just may not be the right study to ask. Right. We don't know. They were training for deployment, so there's all sorts of stuff. These things, as you know, are sensitive to time of day and diet and exercise, and those things are not controlled. Yeah, so that's I think even harder to answer. Obviously, all we've got, I know you've done CSF studies. All we've got peripheral measures. And it's unclear, I think, to the extent to which they reflect any sort of CNS inflammatory process.
It's a very comprehensive presentation of what you call post-traumatic mind injury rather than brain. Brain which signify more structure. But today, you elaborate more of the not just the structural but functional aspects of it, particularly the mind, the mental symptoms. So I think the terminology which you use when I first saw the title, I was guessing, but why you change it now, I realize more of what you intend to say, particularly to this psychiatric audience. Now, you answer the question of resilience. It's very tantalizing. You just say, we are beginning to find something. Could you tell us what is that something? Because we're interested in resilience, and what is that you are beginning to find something? What is that?
What we've been doing is we've pulled together a whole list of candidate genes, which essentially is kind of everybody's favorite neuropsychiatric gene. And we're finding some associations with resilience. We also have had one genome-wide hit for resilience, for self-reported resilience, in an interesting gene that I'll be glad to talk with you about offline, but still not for public.
Okay. The reason I ask this is that in the medical school and in medicine, we are always taught to find the pathological genes. But the other side of the coin is to find the resilience gene in order to prevent illness and also for the longevity. As you can see from the genetic study, genomic study, there is some protective gene for manifestation of cancer. So that kind of line of research seems to be very, very important. Now come to the more practical question. You, in conclusion, you mentioned that there are two ways of looking at it, treatment. One is anti-inflammatory, and one is the stimulant. At what point you decide, do you need a laboratory test or do you need anything? At what point in the longitudinal course you are starting to use the anti-inflammatory, for instance, aspirin, before going to Afghanistan? Or at what point you need some laboratory evidence to say, now from our own study too, it's a very, very good evidence that the anti-inflammatory seem to be playing a very important role. Then at what juncture you start to use methylphenidate? So this is the more practical for us.
Right. Those are kind of the million-dollar questions that we're far away from having answers to. So there's been a lot of interest in trying to do this. So these all require trials. You've got to do clinical trials to answer these questions. They haven't been done. There's been very little interest until recently, particularly by the pharmaceutical companies. These are expensive studies to do. We need studies that actually take individuals who are going to be at very high risk for being exposed to trauma, give them something that prophylactically could prevent PTSD, hopefully something benign, if it were as benign as aspirin or something, that'd be great, and actually determine whether or not they're preventative. Those are hard trials to do, in part because fortunately, no matter how bad the trauma is, you're only still going to get 20 or 30% of people who are going to develop something. So power it up requires a really big study. And then the other part of it of, when would you transition from trying to do something preventative to sort of engage healing processes to then, now you've got a chronic condition and there's different physiology, which I think there is, when you switch treatments. We just have no idea. And the animal models we have don't answer the question well. either animal models can model for us avoidance, they can model part of physiologic fear response, but humans are a lot more complicated, and we avoid in subtle ways, and we experience distress in subtle ways that the animal models can't really tell us. So basically, we hope that there's going to be a lot more clinical trials. In the past year or so, there's been a whole lot more interest by the pharmaceutical companies in doing trials and getting into the PTSD space. And so I'm hoping we'll have more answers to your questions in the next couple of decades. I'm optimistic.
So I'm pretty sure maybe you can tell me, I think that the dopamine neurons are particularly vulnerable to repeated head injury and concussions. And I was just sort of thinking about your methylphenidate findings. I don't know if there's any connection there. And I was also curious if there's more information sort of emerging about, which parts of the brain are particularly vulnerable to head trauma.
I don't know about dopamine neurons. Anybody else know in terms of susceptibility to? Right. So I mean, they're definitely right. There are models where you do get dopamine neuron loss, you get Parkinson's. Right? Yeah, but I don't know that you see the Parkinsonism because of the separation. The second part was, yeah. So most car accident TBIs, most sports concussions, are going to involve either a direct or a pre-concussive frontal cortex injury. And so I think the thinking for a lot of concussions is that you're damaging or you're taking offline frontal cortical and prefrontal cortical systems and their connections with other parts of the brain. And what you see in imaging studies is you don't always see it on CT, you can see it in MR, and if you're looking at diffusion studies, you can see shearing of connections between frontal cortex and limbic system, even within frontal and prefrontal. So it's a lot of connections being either torn or shocked, and dysfunctional for a period of time. Yeah, what else would we add? Do you have a question? Oh, Mike, I get it. Mike's getting the mic. Okay, then back to Beth after.
I wanted to go back to the point you were making about pleiotropy, which, in light of some of the premorbid risk factors for developing symptoms, are really interesting. It makes me wonder if there might be a way to actually eliminate a psychiatric disorder rather than to add one. Where can you think of this as maybe major depression at a late clinical stage with the addition of a brain injury or an emotional trauma, where these are sort of similar disorders early on, and you're adding something on top of it? Or can you just comment on that? And might your GWAS data inform that if you look for pleiotropy between PTSD and major depression?
The second part's easier to answer than first because we did that, and we didn't see pleiotropy between. Now remember, what we're doing there is we're going to GWAS studies in major depression and asking, which genes are associated with major depression. And of course, as you know, there are no people that get found at the GWAS level. So major depression itself is very heterogeneous, and that's probably part of the reason they haven't found it. And then we're going in and asking, do we see pleiotropy with PTSD in our samples? And the answer is we don't. But that major depression group is probably a real mix. There probably is a subset in there that there would be a lot of pleiotropy with PTSD. How do you find them? That's the question. I think the way you find them is eventually, put together these great big cohorts of PTSD and major depression samples. You have enough power to do that, and start to find subgroups. Once we get to that point, then this is going to become much more this is PTSD where maybe they had premorbid major depression, or they had premorbid, or they had risk genes for major depression. And when they get traumatized, here's what they look like. Here's another group that doesn't have that. Might get treatment. We're kind of poised to be able to do that. I mean, schizophrenia, they're now up to the Psychiatric Genomic Consortium. I think it's like over 100,000 cases in there. And in PTSD, we're now at about almost 10,000 cases. But it's going to get to the point where it'll let us start.
Which is about lithium and the neuroprotective effects of lithium and whether that's been studied in these conditions and also the anti-suicidal effects.
I don't know. I don't think lithium, as far as I know, I don't think it's been studied in PTSD. I don't know if it's ever been studied in, say prophylactically for TBI or after an injury. I actually don't know. No, it's an interesting suggestion. There's lots of companies looking for new lead compounds to look at for TBI combo. Yeah.
So we've had a right frontal distribution for our questions here. I was wondering if any of the rest of the room had questions. We're moving a little bit more posterior.
I had two questions. One was, should we be ordering neuropsych testing for TBI patients? Because I've been ordering it and I just haven't found it helpful for those that have had TBI. So that's one question. The second question was, have we looked at post-concussion symptoms in terms of the course, the syndrome, and in terms of how they looked afterwards and resolved, whether or not they resolved and within a certain amount of time, and then after a certain time, if it hasn't improved, will it pretty much just they would continue to have the syndrome? So,
I mean, I guess the indications for neuropsych testing would really be if you thought the individual was having impairment that you wanted to characterize better, and if you wanted to get some feedback on interventions that might be helpful. So I think for a lot of people, the answer is probably yes. I'm sorry, what was this? What was part two? So I mean, we haven't, because we have just this snapshot of individuals, 8,000 individuals. But there are studies that have been done. Some of the best studies are those that are ongoing. So the NCAA has concussion studies ongoing. Mike McRae at Wisconsin is the PI. And they're doing neuropsych testing and some mental health testing in college athletes before they start their careers. And then they're doing routine surveillance of individuals throughout. And then they also do testing when people sustain a concussion. And they're comparing football players to basketball players to swimmers. And I think that's going to give us the best portrait of kind of what the natural course of these kinds of problems are, and tell us a lot about risk factors as well.
Other questions? Well, Murray, thank you so much for this stimulating talk this morning, and thank you all for participating.